From Chicago, this is Audio Digest Surgery, Volume 17, Number 18, highlighting 8 reports from the 11th Annual Meeting of the Society for Surgery of the Alimentary Tract. To begin our coverage, Eric J. Lazaro of New Jersey College of Medicine pinpoints some significant clinical pathological findings in his study of fatal acute pancreatitis. Dr. Lazaro?
There were 50 cases from the college hospitals and 30 from the medical examiner's files. The average age of the hospital patients was 54.2 years, and that from the medical examiner's office, 39.7 years. The sex ratio in the two series was almost identical. The general clinical description or initial diagnoses of the hospital patients, as noted in the emergency room sheet, acute pancreatitis had not been considered in any of the patients initially. 5 patients appeared to have developed their pancreatitis after admission. 1 was admitted for an elective hernia, having no acute abdominal symptoms at the time of admission. 3 patients developed pancreatitis postoperatively, and 1 suffered accidental cold exposure with resultant hypothermia. The working diagnoses developed after admission. Pancreatitis was suspected in 7 cases, while the rest were diagnosed as having a variety of clinical states. In only 11 patients were amylase values determined. 4 patients had values less than 150 units, 5 between 150 and 500 units, and 2 over 500 units. The major clinical features of the patients, none had typical manifestations of acute pancreatitis. They predominantly mimicked acute hepatocellular disease, acute cholecystitis, shock of undetermined etiology, cardiac disease, and peritonitis. The average duration of the illness prior to admission was 9 days, and the average stay in the hospital was also 9 days. The incidence of the apparent etiologic factors, as determined by the history and pathologic findings, 6 were thought to be due to acute cholecystitis, 1 to calculus and pulmonary obstruction in the presence of a common channel, 4 to infectious hepatitis, and 26 to excessive alcoholic consumption. There were 3 postoperative cases, 2 following common duct exploration, and 1 after splenectomy. In 10 cases, no definite etiology was established. Histologic changes found in the pancreas at autopsy were edema, hemorrhagic necrosis, or suppuration. In the hospital cases, 43 had hemorrhagic necrosis, 6 suppuration, and 1 pancreatic edema. In the medical examiner's cases, on the other hand, 20 had hemorrhagic necrosis, none had suppuration, and 10 had edema of the gland. Extrapancreatic lesions found at autopsy and surgery in both the hospital and medical examiner series. Lesions most often encountered were hepatobiliary disease, gastroduodenal ulceration, renal disease, and left perirenal fat necrosis. The presence of 500 milliliters or more of acidic fluid correlated well with fat necrosis, occurring simultaneously in about half the cases. The preoperative diagnosis of the patients who had surgery were found to have acute pancreatitis, and the nature of the operative procedures that resulted in acute pancreatitis. 1 case was diagnosed as appendicitis, and on exploration, miliary seedings were found which were thought to represent tuberculous peritonitis, but were proven at autopsy to be fat necrosis. There was an inordinately high incidence of misdiagnosis and fatal hospital cases of acute pancreatitis. None of these patients were initially suspected of pancreatitis when first seen in the accident room, and only 14% had a working diagnosis of pancreatitis developed while they were in the hospital and before death occurred. As others have noted, the serum amylase was often normal in these patients, and the average of those obtained was 380 units. These comparatively low levels may occur because patients were later in the course of their disease at the time of admission. It has also been suggested that in very severe pancreatitis, destruction of pancreatic tissue reduces the number of cells generating serum amylase and other enzymes. The great frequency of accompanying related or unrelated pathology often obscure the diagnosis, a common problem being the presence of alcoholic stupor on admission. Histologic lesions subsequently identified at autopsy included a high incidence of acute liver disease in 38 of the 80 patients, gastroduodenal ulcers in 15, and acute cholecystitis in 6. One may speculate on the propensity of acute cellular changes in the liver to generate inflammatory changes in the pancreas, or of pancreatitis to predispose to inflammatory changes in the liver. Patients in the medical examiner series averaged 14.5 years younger than patients dying in the hospital. We suspect that more of these younger patients would have survived if they had reached adequate medical care, and that a larger percentage of patients in the lower age groups who reached the hospital did survive, thus increasing the average age of the patients dying in the hospital. 1/3 of the patients in the medical examiner series had an edematous pancreatitis at autopsy. As Fitz and Simmers have shown, simple edematous pancreatitis may lead to a fatal outcome. However, only 1 case of edematous pancreatitis was seen in patients who died in the hospital under therapy. This would suggest that the effect of hospital therapy prolonged the lives of the hospital patients and either salvaged those patients with edematous pancreatitis or prolonged the lives of patients with this form of pancreatitis until hemorrhagic or suppurative pancreatitis intervened. An implication of the different incidence of lesions found in the hospital and medical examiner series is that the untreated patient died sooner and with a lesion of lesser extent than the patient in the hospital group. It also suggests a normal sequence of lesions, beginning with edematous pancreatitis, which may then develop into hemorrhagic and subsequently necrotic pancreatitis in the same patient.
A question, Dr. Lazaro. Do you operate on all patients who have hemorrhagic pancreatitis?
It is not our policy to operate universally in acute pancreatitis for several reasons. One is we see a fantastic number of cases of acute pancreatitis largely on an alcoholic basis, and most of them respond. Our mortality rate, I would say, over a year is about 3 or 4 cases at each institution. When complications occur or patients are resistant to treatment, then we do explore them with very often gratifying results.
Jerome W. Cantor of George Washington University School of Medicine describes now the problems encountered in diagnosis and management of patients with acute perforation of colonic diverticula associated with prolonged adrenocorticosteroid therapy.
A number of authors have described gastrointestinal complications occurring in patients receiving long-term steroid therapy for a variety of systemic illnesses. Most of these reports have dealt with gastroduodenal ulceration, causing either hemorrhage or perforation. Surprisingly little attention has been paid to perforation of colonic diverticula in patients receiving long-term steroid therapy. A few years ago, in a report from the George Washington University Hospital on our patients with diverticulitis, we noticed that those who had been receiving steroid therapy displayed an increase in morbidity and mortality if they suffered a perforation of a colonic diverticula. As a consequence of this, we reviewed all the patients seen during a 10-year period at our hospital and uncovered 49 patients who suffered perforative complications of diverticulitis. Of these 49 patients, 11 had been receiving long-term steroid therapy. The underlying diseases were rheumatoid arthritis in 4, emphysema in 3, periarteritis nodosa, cirrhosis, multiple sclerosis, and chronic pulmonary fibrosis. Of interest, I want to emphasize 3 of these patients succumbed to their initial disease or to the consequences of resection. We compared the age, race, sex, and site of perforation of the 11 patients who were receiving steroid therapy and the remaining 38 patients who suffered perforated colonic diverticula but who were not receiving steroid therapy. And in these parameters, the 2 groups of patients were comparable. However, when we compared the type of perforation and the outcome, there were distinct differences between these 2 groups of patients. In the group of patients receiving steroid therapy, all but 2 patients underwent emergency operation, in contrast to a significant number of elective operations in the patients who were not receiving steroid therapy. The type of perforation was of considerable interest. Fistulization occurred in 9 patients who were not receiving steroid therapy and did not occur at all in the patients who suffered perforations on steroid therapy. And free or spreading or intra or retroperitoneal infection of a severe degree was quite prominent in the group of patients on steroid therapy and was much less prominent, 18% versus 46%, in the patients who were not receiving steroid therapy. The outcome was again considerably more severe in the patients on steroid therapy. 3 of 11 patients succumbed, in contrast to 4 patients out of the remaining 38 patients who died. In general, it has seemed quite apparent to us that patients who are on steroid therapy have an adverse effect if a colonic perforation occurs. However, the final point arises as to whether or not steroids indeed predispose a patient to a colonic perforation. Our data would seem to support this. Of the entire 115 patients who underwent operation for diverticulitis during this 10-year period, 10% of this group, that is 12 patients, were receiving steroid therapy. 11 of the 12 fall into the group who suffered a perforation of a colonic diverticula. The 1 remaining patient on steroids was operated on for a non-perforative complication. Only 1 of 66 patients operated on for other indications. Finally, the incidence of colonic perforation as a potential complication of steroid therapy may approach the importance that we have heretofore laid to gastroduodenal perforation. And as such, it deserves increasing emphasis. Only with a higher index of suspicion can one hope to institute proper diagnostic measures and appropriate and early surgical treatment.
Dr. Cantor, is it possible that these patients were not having diverticular perforation, but had instead a vascular problem? Collagen disease of the small bowel leading to infarcts that present with perforation from a very small area?
These patients did not have multiple diverticula frequently. However, all of the pathological diagnoses on our resected specimens were diverticulitis with perforation. So unless our pathologist is missing it, that's the only answer that I can give.
Our third report, clinical trial of Agotomy and Pyloroplasty in the treatment of benign gastric ulcer, by John L. Sawyers of Vanderbilt University School of Medicine, who begins by discussing the standard operation, gastric resection.
The standard operation for benign gastric ulcer at the Vanderbilt Medical Center has been a partial gastric resection, usually limited to the distal one half of the stomach. We've been certain that the antrum was removed along with the gastric ulcer. Gastrointestinal continuity is usually reestablished by means of a Billroth 1 gastroduodenostomy. Since 3/4 or more of benign gastric ulcers occur in the pre-pyloric area or along the lesser curvature of the stomach, it has been possible to perform this operation without difficulty in most patients. The Schumacher modification of the Billroth 1 operation permits excision of the gastric ulcers on the lesser curvature of the stomach, except for those up in the cardia, and preserves sufficient gastric reservoir to prevent anemia and nutritional difficulties. Now, in review of 140 patients with benign gastric ulcer treated by resection, we had good to excellent results in 90% of the patients with a 12-year follow-up. The mortality rate was 2.8%, and the 4 patients that died all had bled massively and undergone emergency operation. Recurrent ulcer developed in 4 patients, or 2.8%, none of whom had an associated duodenal ulcer. These patients had re-resection combined with vagotomy. Because of this experience, we have added vagotomy to the operation in recent years. The findings of Ferguson and others that complete gastric vagotomy reduces the sensitivity of the parietal cells to humoral agents lend support to the concept of vagotomy in the management of benign gastric ulcer. Now, when Drs. Ferris and Smith reported to the American Surgical Association in 1963 excellent results in 15 patients with benign gastric ulcer managed by vagotomy and pyloroplasty, with a gastric ulcer left in situ, we began to treat a few patients by this method. Since clinical studies both support and reject the effectiveness of vagotomy and pyloroplasty for the management of gastric ulcer in the absence of associated duodenal ulcer or hypersecretion, we decided to do a clinical study of vagotomy and pyloroplasty in the treatment of benign gastric ulcer in patients seen at the Vanderbilt University Medical Center. Now, a total of 48 patients with benign gastric ulcer and no X-ray or operative findings of associated duodenal ulcer have been managed by a truncal vagotomy, a 1-layer pyloroplasty as described by Weinberg. The gastric ulcers were biopsied by the 4-quadrant technique and immediate cryostat pathological examination performed to rule out malignancy. And no patient in this series has developed a gastric carcinoma on follow-up examination. And we've divided the patients into 3 groups. Group 1 consisted of 22 patients who underwent elective operation for an intractable gastric ulcer. 18 patients had an emergency operation for massive bleeding from gastric ulcer, and 8 patients who had been on ulcerogenic drugs, aspirin, reserpine, or steroids, had emergency operation for massive bleeding. Now, we did not include any patients with a so-called stress ulcer, that is, acute gastric ulceration developing after trauma or major operation. Now, the reported results of vagotomy and pyloroplasty in the treatment of gastric ulcer, these are reports in recent years. Dorton, 30 patients with a 7% recurrence. Ferris and Smith report no recurrence. Dr. Stemmer has the highest recurrence rate, 38%, and we had 15% in this study. Now, in addition, Dr. Woodward, in a paper presented to this society, warned of the dangers of pyloroplasty for the treatment of gastric ulcer and reported 4 patients with a recurrent gastric ulcer. He implied that a 1-layer Weinberg pyloroplasty was not a good drainage procedure, and that anthrostasis increased gastrin production and led to recurrent gastric ulcer in the patients. Connolly and his group, however, have not found evidence of gastric retention on routine gastrointestinal X-rays or barium meal studies. They report recently a 40% incidence of recurrent gastric ulcer in 38 patients treated by drainage procedures with or without a vagotomy, and have stated it is difficult to explain the recurrence of gastric ulceration after vagotomy and pyloroplasty on the basis of antral stasis or incomplete vagotomy, and we would certainly agree with that statement. Our clinical trial doesn't answer the question why there's such a reported difference in the results of vagotomy and pyloroplasty in the management of benign gastric ulcer. I do think it is important to differentiate between gastric ulcers. One can't fairly compare the results of a gastric stress ulcer or a steroid-induced ulcer with a solitary gastric ulcer probably induced by antral stasis. If we eliminate the 8 patients who were on ulcerogenic drugs from our study, we would have 40 patients with only 1 death, but still have an ulcer recurrence rate of 12.5%. Because of that recurrence rate, we feel that vagotomy and pyloroplasty in the management of benign gastric ulcer should be reserved for the patient requiring emergency operation, particularly the geriatric or poor-risk patient, if he has not been on ulcerogenic drugs. Vagotomy and pyloroplasty has not been as satisfactory as resection and vagotomy for managing the intractable benign gastric ulcer.
Dr. Sawyer's co-author, Charles Graham, offers a response to the question, how many patients who were taking ulcerogenic drugs took them in the postoperative period? Also, is there any data on the use of gastric resection for patients who are on ulcerogenic drugs?
One of our patients that was on the ulcerogenic drugs did continue preoperatively. This was one patient on steroids for arthritis, and this was one of the patients that did rebleed. We are accumulating the data for the other question, and we do not have the answer to that at present.
Now, an opposing viewpoint. Richard O. Kraft of the University of Michigan Medical School, who favors vagotomy and pyloroplasty as the treatment of choice for gastric ulcer, in his discussion of vagotomy and the gastric ulcer. Dr. Kraft?
First of all, in reference to the technical aspect of the operation, we are absolutely convinced that vagotomy is part of this operation for benign gastric ulcer. Early in our experience, we actually resorted to the old Balfour operation with gastric drainage alone, along with biopsy of the gastric ulcer and with a high recurrence rate. And we no longer do the procedure without vagotomy. I would agree that the mechanism is probably gastrin release potentiation and parietal cell responsiveness potentiation. We very strongly feel that the Heineke-Mikulicz or Weinberg pyloroplasty is an inadequate gastric drainage, specifically for the gastric ulcer patient, and we strongly favor either the Finney pyloroplasty or the Jabelet pyloroplasty. We've had a few patients who have come back with gastric retention at 1 hour after a perfectly adequate Heineke-Mikulicz or Weinberg pyloroplasty. Now, in reference to our own clinical material, 156 patients at the present time. I think it's important to point out to you that our standard operation in Michigan is subtotal gastric resection. These patients are adversely selected for vagotomy and pyloroplasty, and hence a very high operative mortality rate. I can justify this to some extent, but I'm not going to dwell on it. The operations are dominantly in patients who are elderly and infirm, and of the 14 operative deaths, 11 were over the age of 70, and 10 were for massive hemorrhage. Indications for operation were those acceptable in peptic ulcer series. Emphasis on massive hemorrhage in the elderly patient, again, adverse selection at our institution. Operative mortality, dominantly in the massive hemorrhage group, and as I mentioned, 11 of 14 over the age of 70. An incidence of 3% of elective operative mortality. Again, in an elderly group, those who would challenge vagotomy and pyloroplasty as to its mortality, of course, are fighting a losing battle this day and age. The summary from the Commission on Hospital and Professional Affairs, summating some 46,000 subtotal gastrectomies in the last 3 years against some 17,000 vagotomy and pyloroplasties, indicates a 2-to-1 mortality ratio, and this is where most of the gastric surgery is being done. This data represents 1 out of every 4 hospital discharges in this country today. Carcinoma, the potentiality of the benign ulcer actually being a carcinoma still is important. Nowhere near the old 10% that we used to quote, but still important. In our data, 4% of these lesions that were excluded from the study by any consideration of possible carcinoma, that is cytology, suggestive röntgenographic appearance, and so forth, and yet we still had 6 patients with carcinoma. These patients do well. 5-year cures in 3 of these 6 patients, 50%, which is compatible with the literature in this regard. We do biopsy alone, not wedge excision. We've had 100% accuracy in this regard. No false positives, no false negatives. A few were questionable on frozen section, substantiated on permanent section. Incidentally, I should point out that all stress ulcers and parapyloric ulcers were excluded from this study. I think they represent a different problem. Duration of follow-up, I think we're now starting to talk about something significant. We have 62 patients followed longer than 5 years, 31 patients followed longer than 7 years, 118 patients followed over 1 year, no patient lost to follow-up. Recurrent ulcer, 5%. 3 of these had positive Hollander tests. I'm embarrassed to point out that 3 didn't have a Hollander test done. It's impressive that 2 of those with positive Hollander tests had transthoracic vagotomies and are doing well on fairly long follow-up. I think that the vagotomy, again, is confirmed as an important facet to this particular operation. Postoperative sequela, vagotomy and pyloroplasty is accepted as the least morbid of all acceptable peptic ulcer operations, and I think this data confirms this. The incidence of diarrhea and dumping was responsible for 2 dissatisfied patients who did not have recurrent ulcer disease. We accept those as failures without recurrent ulcer disease. The incidence, incidentally, of adverse side effects was much less in the gastric ulcer group with the same operation as contrasted to the duodenal ulcer group with vagotomy and pyloroplasty, perhaps an important factor. We consider vagotomy and pyloroplasty an adequate, excellent, safe operation for gastric ulcer disease, and do recommend it to you for consideration as either an alternate procedure in high-risk patients or perhaps even, as I feel, the primary operation in these patients.
Dr. Kraft, how does the risk of vagotomy and pyloroplasty compare with that of gastrectomy?
All I can say is that the demonstration of vagotomy and pyloroplasty as being less risky than gastrectomy is absolute in my mind, and do you judge friend from foe in this selection, high risk, low risk? I think that there's no question now that vagotomy is a lesser operation.
Our next report from the SSAT meeting, a study of the causes of failure of esophagocardiomyotomy for achalasia by Paul Mamier, Jr. of the University of Pennsylvania School of Medicine. Here he is.
In 1948, we began using the operation of esophagocardiomyotomy and the surgical treatment of achalasia of the esophagus. This report is concerned with the analysis of 114 cases studied at the Graduate Hospital with a follow-up of at least 3 up to 20 years. 40 patients have been treated conservatively alone with 2 deaths. While it is to be stressed that almost all of the patients had at least 1 dilatation, the dangers attendant upon bouginage are borne out and reinforce the soundness of abandoning conservative treatment early, especially in cases with a widely dilated esophagus. 74 patients have received esophagocardiomyotomy with 1 death. 75% had a good to excellent result, and 18 or 25% were classified as fair or poor results. 6 of these 18 patients were operated upon elsewhere and referred when symptoms recurred. Analysis of those classified as having unsatisfactory results reveals certain factors common to a significant number to suggest prognostic importance. 16 had long-standing disease, 14 had multiple previous dilatations, 3 also had esophageal diverticula, and 8 had severe scarring around the esophagogastric junction specifically mentioned at the time of myotomy. Secondary operative procedures were carried out in 11 of the 18 cases. 3 of the 6 had a repair of a hiatus hernia, vagotomy, and pyloroplasty. 1 of the patients with obstruction at the esophagogastric junction had a Grandal procedure and pyloroplasty. 1 with obstruction at the pyloroduodenal area had a pyloroplasty alone. 3 of the patients with esophagitis and stricture had interposition procedures. 1 with an obstruction at the pyloroduodenal area had a subtotal gastrectomy, and 2 of the patients had a second Heller operation, the second myotomy. 7 of the 11 have now been rendered essentially symptom-free. Thus, following the second procedure, 85% may now be classified as having good to excellent results. Careful repair of the hiatus at the initial operation plus an emptying procedure at the pyloroduodenal area would have decreased by at least 40% the unsatisfactory results. In the remaining, while there is no obstruction, they continue to have some symptoms which are controllable on a medical regimen. Oral procaine has been helpful in some cases. We believe that there is substantial evidence that the routine addition of an emptying procedure at the pyloduodenal area in conjunction with esophagocardiomyotomy is worthwhile. We and others have noted a marked delay in emptying at the pyloduodenal area in some cases of achalasia after the obstruction at the EG junction has been relieved. Secondly, it is of interest to note that of the 11 patients who subsequently necessitated a second procedure, only 2 had had pyloroplasties at the initial procedure. On the other hand, 5 of the 7 patients who have been managed satisfactorily on a medical regimen without subsequent operation have had pyloroplasty. It is probable that a drainage procedure at the pyloduodenal area decreases the severity of regurgitation esophagitis should it occur. Our more recent studies have continued to show a 40% incidence of regurgitation when specifically looked for following esophagocardiomyotomy, and esophagitis has occurred in 18% of the total cases. A perplexing aspect of the operation is the multitude and the variety of ways in which it is done, yet with essentially similar results in most reported series. In Heller's original article, he made an incision both anteriorly and posteriorly for around 8 centimeters, stressing the importance of continuing the incision downwards. There has been since every gradation between the 1 or 2 centimeter incision on the esophageal side only, advocated by Silber, to the very extensive incision extending from the aortic arch to well onto the fundus of the stomach, advocated by Fontaine, and all variations in between. Ellis uses a 6 to 12 centimeter primarily and almost entirely on the esophageal side alone. Grimes and Stevens from the inferior pulmonary ligament onto the surface of the cardia. We have felt that 2/3 of the incision should be on the esophageal side and 1/3 on the cardia. The goal to be desired by incision appears to be one which is long enough to appropriately reduce the resting tone in the region of the inferior esophageal sphincter, and one which at the same time avoids impairment of gastroesophageal competence. It is likely, however, that the operation is too imprecise to tread this narrow line.
Dr. Namir, how far should the incision extend down onto the cardia of the stomach?
The incision which we have used has been one extending for a distance of around 8 to 10 centimeters, with 2/3 of it being above the esophagogastric junction and extending onto the gastric side for 1 to 2 centimeters.
And this, Doctor, is the end of Side A of your program. Side B may be heard by just flipping over the cassette or 2 reels on your machine. Continuing a report from the 11th Annual Meeting of the Society for Surgery of the Alimentary Tract, held in Chicago, this is Side B, Audio Digest Surgery, Volume 17, Number 18. The topic of our 6th discussion, use of an elemental diet in nutritional management of fistulae of the gastrointestinal tract. As Catherine Barry of Rhode Island Hospital describes indications for the diet, evaluates results using the diet, and lists complications encountered to date. Dr. Barry?
This presentation reports 13 cases of patients with fistulae of various portions of the alimentary tract in which elemental diets provided adequate nutritional support. In all cases except lower bowel, drainage well exceeded over 200 cc's per day, 48 hours after diagnosis. All the fistulae developed post-operatively. Inflammatory bowel disease was concurrently present in 2 cases and carcinoma in 1. In 10 of 13 cases, the fistulae developed between 1 and 11 days post-operatively. In 2 cases, they were the reason for admission, but initially had been post-operative events. In all cases, sepsis was a major complicating factor. Elemental diets were the main or sole source of nutrition in these patients for periods from 5 to 50 days. 2 main types of chemically defined diets are available: Codalid from Schwartz Bioresearch and Vivonix from the Vivonix Corporation in Mountain View, California. All diets contained purified L-amino acids as the sole source of nitrogen, either sucrose or glucose as the carbohydrate source, and are virtually fat-free. They contain all the known micro and macronutrients in recommended quantities for human nutrition, except cobalt and vitamin K. On reconstitution with water, these diets form clear solutions. Weight-volume composition can be varied as desired. At 25%, they contain 1 calorie to the cc, and if glucose-based, have an osmolality of approximately 1400. If sucrose-based, this is decreased to approximately 800. These diets provided adequate nutritional support without exacerbating fistula drainage. Positive caloric and nitrogen balance was achieved in most patients. While on diet, weight was maintained and serum proteins significantly increased. Over 50% of the fistulae closed spontaneously, and the mortality rate was 15.4%. This suggests that the use of such diets provides an effective method of maintaining nutritional support of patients with fistulae of the alimentary tract. Chemically defined diets have several characteristics which make them particularly advantageous in the management of fistulae. They are bulk-free and decrease stool volume and frequency. They require little digestion and are virtually fat-free, and thus they are relatively non-stimulating of pancreatic, biliary, and intestinal secretions. They are absorbed completely by the duodenum and upper 100 centimeters of jejunum. And finally, glucose diets in high concentrations may decrease intestinal flora. Route of diet administration should be dictated by patient tolerance and the type of fistula involved. Patients with fistulae proximal to the ligament of Treitz can be fed intrajejunally. In small bowel fistulae, the diet may be given orally, intragastrically via a small pediatric nasogastric feeding tube, or into a gastrostomy. The diet should be delivered slowly and continuously over 24 hours. We usually use a Barron pump for this. Initially, it is wise to begin with a 10 or 15% weight volume concentration and gradually increase both concentration and volume one at a time over a period of 4 to 5 days. With concentrations above 25% weight volume, additional water is mandatory to prevent hypertonic dehydration, and such concentrations are seldom advantageous. Additional amino acids and electrolytes may be added to the basic diets if required. With progressive increase in diet administration to patient tolerance, complications are rare. A list of complications was compiled based on our overall experience with approximately 100 patients with various disease states. Delayed gastric emptying or gastric retention with hypertonic intragastric feeding may occur. Aspiration is a hazard if using a nasogastric feeding tube, and in elderly or debilitated patients, it is sometimes wise to discontinue the diet at night. With a sudden change from a high fat to a high carbohydrate energy substrate, as from starvation to hypertonic feeding, fluid retention may occur. A gastrointestinal hemorrhage occurred in one patient in our series of patients with fistulae within hours after administration of the diet. However, a cause-effect relationship was not demonstrated and coincidence probable. Hypoprothrombonemia will result if supplementary vitamin K is not provided. We usually give 10 milligrams 3 times a week.
Dr. Berry's co-author, Harry T. Randall, answers this question. Since this diet is rather hyperosmolar, is there danger of the dumping syndrome occurring in patients after pylorectomy or gastrectomy?
If anyone who had no pylorus were to take a substantial bolus of these hypertonic materials at one time, undoubtedly that individual would dump. As a matter of fact, it's possible by feeding an individual a glassful of some of these materials to produce dumping even in someone with a pylorus intact. But I think the secret to this lies in the fact that they are administered continuously or in very small, very frequent amounts, that no one particular time, is there sufficient osmolarity increase within the gastrointestinal tract to produce the distension, the shift of fluid volume, and the release of sympathetic type overflow that one sees in the dumping syndrome? It's a matter of route, it's a matter of rate, and it's a matter of the fact that the gastrointestinal tract will very rapidly equilibrate any hypertonic material. And if there isn't too much, very soon within the stomach alone, or certainly within the upper small bowel, there is isoosmolarity, which is probably necessary to achieve significant absorption.
Combined parenteral hyperalimentation and chemotherapy in the treatment of disseminated solid tumors may be a valuable approach, as suggested by the experience of Gordon F. Schwartz of Jefferson Medical College. Dr. Schwartz?
Since the initiation of systemic chemotherapy in patients with disseminated malignant disease is usually predicated upon unpleasant symptoms which may be ameliorated, most of the current chemotherapeutic agents have been used only in the presence of such symptoms, or when rapidly progressive disease will shortly give way to these unpleasant symptoms. Often, patients have not been treated because of the toxicity associated with most of these agents. Unfortunately, it is the patients whom clinicians are most often called upon to treat, those with progressive, symptomatic, widespread metastases, who are usually considered the poorest risks for systemic chemotherapy. The observation that parenteral nutrition alone can achieve weight gain, increased strength and activity, and a positive nitrogen balance led us to inquire whether parenteral hyperalimentation with an amino acid carbohydrate solution would be a useful adjunct to systemic chemotherapy in selected patients with advanced malignant disease. Patients with histologic proof of malignancy and progressive symptomatic demonstrable widespread disease were included in this study. The following categories of patients were excluded. 1, those with heart failure or significant pulmonary disease which might lead to right ventricular failure while on hyperalimentation. 2, those for whom a more conventional type of therapy was appropriate, such as external radiotherapy for symptomatic bone lesions. 3, those who had recently received external radiotherapy to a measurable lesion or who had undergone systemic chemotherapy within the previous 4 weeks. 4, those receiving steroids or other hormonal therapy except thyroid or insulin. And 5, those patients with histologic proof of bone marrow replacement by tumor. The treatment schedule called for the institution of hyperalimentation following the percutaneous placement of a subclavian venous catheter directed into the superior vena cava, and the continual delivery of increasing volumes of hypertonic protein hydrolysate and glucose solutions at a constant rate, using a Holter pump and an inline millipore filter to ensure constancy of infusion rate and sterility. The initial load was to be 2,000 milliliters of fluid per day, providing approximately 1,300 calories. This intake was to be increased gradually to a maximum of 4,400 milliliters and 3,400 calories on the 14th and each subsequent day of hyperalimentation. The chemotherapeutic agents chosen were 5-fluorouracil, 5-FU, and cyclophosphamide, Cytoxan, depending upon the site of origin and the histology of the tumor. Chemotherapy was to be initiated 5 to 7 days after the commencement of hyperalimentation. 5-FU was to be given in a dose of 15 milligrams per kilo per day for 5 days, then 7.5 milligrams per kilo on alternate days until toxicity necessitated the cessation of therapy. Following the recovery from toxicity, if the patient's condition permitted, 5-FU was to be reinstituted at the alternate day dosage schedule until a second episode of toxicity occurred, at which point chemotherapy was to be terminated. If toxicity occurred, parenteral hyperalimentation was to be continued without interruption but electively terminated 1 week following the last dose of chemotherapeutic agent. Cytoxin, when used, was to be given intravenously in a dosage of 8 milligrams per kilo per day for 5 days, then 5 milligrams per kilo on alternate days until toxicity occurred. Following recovery from toxicity, 50 to 150 milligrams per day by mouth were to be given to maintain a leukocyte count between 3 and 5,000 per cubic millimeter. Again, hyperalimentation was to be continued without interruption and terminated 1 week after the last dose of Cytoxin. All patients were to be allowed a free choice of diet throughout the course of study. 12 patients entered the study, 3 each with disseminated colon and mammary carcinoma, 2 with gastric carcinoma, and 1 each with ileal carcinoid, carcinoma of the cervix, squamous cell epithelioma of the esophagus, and squamous cell epithelioma of the lung. All patients were considered poor risk candidates for chemotherapy by the criteria previously mentioned. 10 of the patients received 5-fluorouracil. The 2 patients with squamous cell epithelioma of the esophagus and of the lung received Cytoxin. 2 of the patients treated with 5-FU, both women with mammary carcinoma, were unable to complete a course of therapy because of inability to tolerate the parenteral hyperalimentation. They are therefore excluded from further discussion. For the 10 patients who completed therapy, the period of treatment ranged from 14 to 84 days. The average duration of therapy was 46 days. The mean dose of 5-FU administered was 134 milligrams per kilo, approximately twice the recommended course of therapy outlined in the package circular. 3 patients received a total dose of 5-FU considered by the manufacturer to approach the LD50 for that drug administered as a single course of therapy. The maximal dose administered to a patient during this study period was 235 milligrams per kilo over 72 days. A second patient received 233 milligrams per kilo over 84 days. Because of the absence of toxicity, except in the patients who developed marrow depression, the endpoint of this study as originally designed, namely the conclusion of chemotherapy at the first or second toxic episode, was not reached in any but these 3 patients. The remaining 7 patients received combined therapy for periods in excess of 1 month. 1 patient died suddenly on the 36th day, and the other 6 patients had their chemotherapy discontinued on the day indicated. We had not initially expected the gratifying results in terms of patient well-being, decreased analgesic requirement, reversal of downward weight curves, and improvement in performance status. And in the early period, we did not continue the administration of 5-FU and Cytoxin over an indefinite period of time. As the patients did well, we continued the therapy as long as it seemed reasonable to keep the patients hospitalized. Therefore, these 7 patients determined their own endpoints by requesting discharge from the hospital, and toxicity was never reached. Equally as striking as the improvement on combined therapy was the progression of the downward course of most of the patients following discharge. It was as though the combined therapy had interrupted the inexorable course of the illness for a period of time, but the disease progressed unchanged after the conclusion of therapy. The unequivocal efficacy of combined parenteral hyperalimentation and chemotherapy can hardly be concluded from these observations made in a small selected group of dissimilar patients following a protocol which did not even include a control group of patients. But the impression remains, however, that this technique has been successful in promoting a sense of well-being in the treated patients, along with increased appetite and oral intake, improved performance status, decreased analgesic requirements, and positive weight changes. By adding hyperalimentation to chemotherapy, we have been able to convert a small group of poor risk candidates to a better risk with a marked absence of gastrointestinal toxicity and a rapid reversal of marrow depression when it occurred. The additional observation that further progression of metastatic disease has been only postponed by this technique has led us to search for a method of providing continual therapy on an outpatient basis. We are currently exploring the use of a battery-operated pump and plastic infusion bags to enable patients to continue combined therapy at home.
One question, Dr. Schwartz. Did you do any balance studies to know exactly how this nutritional supplementation affected nitrogen retention, potassium retention, and body fluid compartments?
No, we did not do any balance studies in this group of patients, but we are currently in the process of planning just that thing after these observations were sort of brought home to us by how well subjectively these patients did.
In his report of 21 cases of carcinoid islet cell tumors of the duodenum, our final speaker, Rudolf F. Weichert III of Tulane University School of Medicine, suggests that these tumors may be more common than the literature indicates. Dr. Weichert?
In the past 15 years at Charity Hospital in New Orleans, we've had 21 patients with interesting duodenal tumors. The typical appearance of these tumors in the duodenal wall. These tumors arise from the mucosa, but are located primarily in the submucosa. They have all occurred at or proximal to the ampulla of Vater, and they can be located anywhere on the circumference of the bowel. Histologically, they are indistinguishable from both foregut carcinoids and islet cell tumors of the pancreas. And for this reason, we have designated them carcinoid islet cell tumors. The tumors in our series have ranged in size from 5 millimeters in diameter to 1.5 centimeters in diameter, and yet 1/3 of them were malignant, and most of them had metastasized. Despite the small size of these tumors, they have been responsible for an interesting array of symptoms, the manner in which the 21 patients presented. 8 of them had the Zollinger-Ellison syndrome. 5 had a duodenal ulcer, but without proven hypersecretion. 3 were found as incidental autopsy findings, and 4 had vague dyspeptic complaints and were found on GI series in 3 patients and incidentally at cholecystectomy in another one. And 1 patient presented with obstructive jaundice with a tumor obliterating the ampulla of Vater. The diagnostic studies that were most useful to us were the upper GI series, which were positive in all patients that had an upper GI series. 4 patients had duodenal polyps, 2 had dilatation of the duodenal loop suggestive of the Zollinger-Ellison syndrome, and the remaining patients had duodenal, esophageal, or marginal ulcers. Gastric analysis was the most important prognostic and diagnostic test. We used 100 milliequivalents of hydrochloric acid in a 12-hour nocturnal aspirate as being diagnostic of the Zollinger-Ellison syndrome, and 6 of the patients that we diagnosed as having ZE syndromes had this amount of acid. The other 2 patients had continued ulcer diathesis and eventually came to total gastrectomy and were found to have residual tumor at the time of total gastrectomy. Gastrin assay was not used in this series of patients, but will be important in the future. 14 of the tumors were benign, or 2/3 of them were benign, and 7 were malignant. 3 important points about the pathology of these tumors which I would like to stress. First, the diagnosis of malignancy cannot usually be made at biopsy since the primary tumors are small and appear benign histologically, even when lymph node metastases have already occurred. Second, if the patient has the Zollinger-Ellison syndrome associated with one of these duodenal tumors, chances are the tumor is malignant and not confined to the duodenum. This was true in 6 of the 8 patients with the Zollinger-Ellison syndrome in our series. And third, the tumors may be multiple. That is, there may be several tumors in the duodenum, or there may be multiple pancreatic islet cell tumors associated with a duodenal tumor. 2 of our patients had multiple duodenal tumors, and 1 had a duodenal tumor and multiple pancreatic islet cell tumors. Multiple tumors in these patients have much the same significance as malignancy. For if one does not recognize that there are multiple tumors at operation, a tumor may be left behind to metastasize or to continue its endocrine activity unabated. Since 3 tumors were found incidentally at autopsy, only 18 of the patients were treated surgically. The crucial factor in the treatment of these patients is the presence or absence of the Zollinger-Ellison syndrome. The 10 patients with duodenal tumors but without gastric hypersecretion are all doing well. 4 of them had benign polyps which were simply excised. 1 had a malignant polyp of the duodenum and pancreaticoduodenectomy and has been doing well for over a year and a half. And 5 patients had duodenal ulcers, and they were treated by gastrectomy and excision of the tumor. The patients with the Zollinger-Ellison syndrome, of which there were 8, have not fared so well. 5 are alive and well, but 3 are dead of endocrine complications. Of the 5 patients who are alive and well, 3 had total gastrectomy after multiple partial gastrectomies. However, 2 patients were cured of the Zollinger-Ellison syndrome by partial gastrectomy and removal of their duodenal tumor. In these cases, we believe a benign ulcerogenic tumor limited to the duodenal wall was removed. Of the 3 patients with the Zollinger-Ellison syndrome who died, 2 had partial gastrectomies and removal of a duodenal tumor, but died in the immediate postoperative period because residual tumor was left behind and continued gastric secretion caused bleeding and perforation. The first patient had multiple ulcerogenic islet cell tumors of the pancreas, in addition to his duodenal tumor. And the second had a single microscopic lymph node metastases. The last patient was the only patient in the entire series who had a total gastrectomy as a primary procedure. But unfortunately, she also had multiple endocrine adenomatosis and died of thyroid storm in the immediate postoperative period. Note that although 2 patients in this series were cured of the Zollinger-Ellison syndrome by partial gastrectomy and removal of benign duodenal tumors, 2 patients with malignant or multiple tumors died because partial and not total gastrectomy was done as an initial procedure. For this reason, we feel total gastrectomy is the procedure of choice in the Zollinger-Ellison syndrome of duodenal origin, just as it is with ulcerogenic tumors of the pancreas, at least until reliable gastrin levels can be done in the operating room and can be shown to drop after complete excision of a tumor. The endocrine activity in these series of 21 patients, 13 patients showed evidence of endocrine activity. There were 8 with the Zollinger-Ellison syndrome, 4 had duodenal ulcers. We believe they were ulcerogenic tumors but had not developed full-blown ZE syndromes. And 1 patient had a duodenal ulcer and evidence of 5-hydroxyindoleacetic acid in the urine. So these patients that histologically appeared to be both carcinoid and islet cell tumors had evidence of both carcinoid and islet cell function.
Are duodenal ulcerogenic tumors more common than pancreatic ulcerogenic tumors, Dr. Weichert?
In reviewing the islet cell tumors at Charity Hospital, it appears that the duodenal ulcerogenic tumors are going to be more common in their occurrence than the ulcerogenic tumors of the pancreas. We found about 2 for 1 so far.
Here now, 2 recent and related abstracts of note from the current surgical literature. In over 300 patients with operable cancer of the colon, New York C. Rossiter Kuhner and Associates confirmed the superiority of Turnbull's no-touch isolation technique over conventional surgical procedures. Major features of the no-touch technique are ligation and division of lymphovascular pedicles of the cancerous intestinal segments and division of the colon at elective resection sites prior to manipulation. About 70% of patients having this procedure survived at least 5 years, compared to about 50% with conventional operations. The biggest gain in this series, as in Turnbull's, was in the Duke's stage C group, patients with metastases to regional lymph nodes, but no evidence of further spread. Here, the no-touch technique produced nearly 60% 5-year survival, conventional procedures a low 30%. Rejecting the traditional explanation of rectal prolapse as a sliding hernia, Frank Thurikoff Jr. and his colleagues suggest instead that it's an intussusception beginning at the rectosigmoid junction. With clinical and cineradiographic data to back them up, they report in the Annals of Surgery that intussusception starts accidentally with straining at stool, then recurs with repeated straining. The rectum is gradually loosened from above downward, the fixed point changing to a progressively lower position, the bowel finally protruding through the anus. In 16 years at the Mayo Clinic, the authors report 128 patients operated on for rectal prolapse. The Pemberton operation was done on 68 with 22 recurrences, anterior resection on 28 with only 1 recurrence, and the Altemeyer procedure on 13 with a high 5 recurrences. From these results and a literature review, the authors conclude that repair of the pelvic floor or removal of a deep cul-de-sac, while temporarily successful, does not work in the long run. The Moshewitz and Delorme operations, sigmoidopexy, and rectosigmoidectomy should therefore, they argue, be abandoned as definitive therapy. The Graham, Orr, and Nigro procedures should be limited to those familiar with them, as should the Altemeyer, which these authors have now abandoned, despite successful results by the originator. The recurrence rate with the Pemberton procedure is high, but its low mortality justifies limited use in the fair-risk elderly, especially when the rectal stalks are sutured to the sacrum. The preferred procedure for the elderly and debilitated is use of the Thiersch wire. Despite drawbacks necessitating removal in about 1/3 of the patients, the wire can be replaced repeatedly, and the whole procedure can be done in the office. For all age groups, the procedure of choice, they believe, is anterior resection. an operation that eliminates all redundant bowel with eventual fixation of the rectum in the hollow of the sacrum. In doing this procedure, the authors emphasize the importance of mobilizing the rectum all the way down to the coccyx. Some form of temporary Pemberton-type suspension is also desirable. Two other successful procedures, the Ripstein Teflon sling and Wells Ivolon wrap, also fix the rectum in the sacral hollow. Although they may someday replace anterior resection as the treatment of choice, the authors currently advise caution with their use. A problem that none of these procedures can consistently cure is incontinence. Physical therapy and use of pharetic stimulation may be of some benefit, but the only real solution these authors advise is diagnosis of prolapse in its earliest stages by strict attention to suggestive symptoms. And this concludes this September 23rd edition of Audio Digest Surgery, produced and copyrighted by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. Our thanks to the speakers and to the Society for Surgery of the Alimentary Tract for cooperation in recording and disseminating this material. A special note, Doctor, your next issue of Audio Digest Surgery will be mailed to you 3 weeks from now, rather than the usual 2, to spread your 24-issue subscription over the 52-week calendar.